You've heard a couple of talks now that have really focused on, why should we do canaloplasty, the clinical information, those kind of doctor-centric things. The very important, why should I do this? What's in it for me? And although there's been quite a bit of emphasis also on why it's good for the patients, I'm going to focus specifically on what's in it for the patient. Okay, so first of all, disclosure, I am a consultant to eye science. I'm also going to state up front that I'm biased. I am unapologetically enthusiastic about this procedure. Now that enthusiasm did predate my consulting agreement, so my hope is that at the end of this talk, you will understand my bias, but not feel that there's been any conflict of interest. I'm going to suggest to you that glaucoma is a lifestyle disease. Now, some of you in the audience may already see it that way, and to you I apologize, and be patient. But for most of us who think about glaucoma, glaucoma is not what we would consider a lifestyle disease. We think of refractive issues as lifestyle, but not so much glaucoma. And when we do think about glaucoma as a lifestyle disease, we're thinking about it in terms of the end stage of glaucoma, the point at which there's already significant visual field loss. And of course, that's a lifestyle issue. But I'm going to suggest that glaucoma is a lifestyle disease from the very point of diagnosis. And the reason for that is because when we first diagnose glaucoma patients, we as doctors take somebody who is asymptomatic, and by the very act of initiating treatment, we give them symptoms. We impact their lifestyle. And I'm sorry to say, and I think that most of you, if you're honest, have to agree that the impact is not a positive one on that day. Okay. So, how do we impact them? Well, most of us start with drops. Okay. And at a very, very simple level, these drops are expensive. Glaucoma drops, branded, generally average around $80 a bottle. Even the generics can run in the $40 a bottle range. Now, for somebody on one glaucoma medication on a fixed income, that $500 to $1,000 a year is a significant negative financial impact. And that's assuming they're just on one drop. Most of my glaucoma patients are on more than one, and if we're honest, that more than one means three, because one of those is a combination agent, and those really are expensive. But that's not the only medication they're on. Most of our glaucoma patients, just from the fact of the demographics of those who get glaucoma, are old enough to be on multiple other medications. Dr. Sensky mentioned tonight an issue with remembering your medications. Here's somebody who's active, and we know is one of the brightest people in his area. I mean, this Dr. Sensky, we all know of his background, the changes that he's responsible for. So if he's having difficulty remembering his drop and medication schedule, what's the average person doing? Okay. So let's say that you've got Bill Gates in your office. You've just diagnosed him with glaucoma. He says, I don't care what it costs, just treat me. Well, there's still some issues. Bill Gates, as with most of our patients, he's not going to be too happy with the chronic irritation. He's not going to be happy with systemic effects if you give him a beta blocker and it slows him down. Irritation, allergy, things that can range from mild annoyance to, if you live in Southern California like I do, something that can be quite debilitating. I have patients who, because of their ocular surface disease and the worsening from even one glaucoma drop, tell me that they can't read at night past about 15 minutes before their vision just blurs out. That is a significant lifestyle impact. So, am I making too much of this? I mean, these are drops. Is it really that big of a deal? Well, why don't you ask your patients? This is what eye science did. Over 200 patients were asked, would you be interested in a surgical option for your glaucoma? And the amazing thing to me was that 75% of patients on 2 or more drops said, yes, I'd be interested. Even more eye-opening was that of those patients who were only on 1 drop, well over 50% said, yes, tell me more. So the interest is there. So patients are interested. What are we going to offer them? Well, traditionally, we consider things like trabeculectomy, so either argon or selective laser. And there's definitely a sweet spot for trabeculectomy. The problem is that most of the patients who are really interested in a surgical option want to get rid of their drops. And if your patients are on more than 1 drops, SLT or ALT are not going to do it. Well, what about trabeculectomy? It's certainly a surgical option. I think most of us, based on what we've already heard and seen, especially that one slide, that was quite significant, would not feel comfortable offering trabeculectomy to patients who just said, these drops are really bothering me, but our clinical assessment is, yeah, but your fields are looking good. I mean, unless there's actual progression or complete intolerance of medications, most of us don't feel comfortable going on with trabeculectomy. How about shunts and tubes? Well, I mean, these have their own side effect profiles, which still make most of us uncomfortable with the idea of offering somebody this surgical option just because their lifestyle has been impacted. So the question then, is this bad? I mean, is it bad that we are producing lifestyle issues in our asymptomatic glaucoma patients? And I would suggest to you that from the perspective of the alternative, eventual complete loss of vision, no, it's not bad. We are looking into the future for our patients. Okay? We are essentially acting as their parents, just like we do with our children. We do things for them that we know they don't want, but we know is for the good in the future, something that they can't see. And most glaucoma patients are not going to understand the natural history of the disease well enough to understand what that future means. But we have to ask ourselves this question. Okay? Most of us, even those of us who did not take the Hippocratic Oath because it's no longer politically correct, I guess, still abide by the first do no harm. And we do have to ask ourselves this question with regard to initiating glaucoma treatment. Are we truly first doing no harm with those patients? And although I believe that I am, and I would think most of you also believe this, it's not so simple. This is a patient who had trabeculectomy by one of the most talented glaucomatologists, academic ones in my area. It's a beautiful surgery, the bleb looked great, no real objective complications, and the pressure was good. But when it was time for her to go on with her second trabeculectomy, and this is an actual patient of mine, and these are her actual words, I'd rather go blind than have what, from my perspective, was a successful glaucoma surgery. So there's a disconnect here, clearly, between what we view as in the best interests of our patients and what they might view as in their best interest. And we have to consider this, moving forward, especially with the younger patients that are more independent, is that it's not about us. It's not, and when I say that, I mean it's not about what we think is best for our patients. Okay? Paternalism is dead. Now this should be a good thing, right? I mean, we've all been taught that patient-focused care is really the wave of modern medicine. For those of us who were, in medical school over the last 10, 15 years, it just seemed like they were spending way too much time on the touchy-feely stuff and hardly any time on the actual clinical and academic stuff. So from our perspective, this can actually be a bit on the annoying side. But if you're not aware of it, you're not going to get through to your patients. You have to be aware of certain things. Orders have kind of morphed into professional suggestions, whether it's with your nurses, sometimes even nurses' assistants, or your patients. You have to recognize that you can't just order them to do something and expect that they're going to do it. And for those of you who have been in practice for over 20, 30 years, you probably remember fondly, I imagine, those days when you'd write a prescription for something even like pilocarpine or propine and tell the patient to take it and come back in a month and you'll recheck the pressure. And when they came back in a month, what happened? Well, they were probably actually taking the drop. They may have been hating you for it, but they were taking it because you told them to take it. And then you'd have the chance to discuss the drop, the side effects, and compare it to the effect. Well, what happens today? You send somebody home with Travetan Z, which is supposed to be one of the gentler of the prostaglandin analogs. And in my experience, in my practice, they have a little bit of irritation. They stop taking it after a day or so. Don't let me know about it, but they come back and say, well, I didn't take it. Well, I now, what do I do? Okay. So the problem with medicine now is that there are these irritating eyes, the internet and the insert. Okay. So what do we do? How do we get through to our patients? Well, one way is to actually use some information gained from marketing. Okay. Now, in medicine, we study how to cure and treat disease. In marketing, they study what makes people tick. What are their desires, wants, and needs? And one of the things that we can do is we can actually learn quite a bit from marketing. Because if we figure out what our wants, desires, and needs of our patients are, then we can actually figure out how better to communicate with them and develop a treatment paradigm that will work for them. Baby boomers consider themselves ageless explorers. They want to be active. They're in denial about their age. Don't call them old. Every time they're reminded of their age, they dislike it. What happens when they take a drop? They're reminded of their age. And they ignore the consequences of advancing years. And if you've got an asymptomatic disease, that's a whole lot easier to ignore than a symptomatic one. So what do we do for our patients who are focused only on the now, want to stay active, are quite frankly ambivalent about your suggestions, and are in active denial about their aging? Well, one thing I'm going to suggest is that we give them what they want. And what they want is a surgical fix. So how do we fix glaucoma? Well, we have to think about what would be the ideal fix. And I think that a surgical fix from their perspective would be ideal because it would eliminate the drops and the constant reminder. Well, certainly if we're going to give them a fix, it also has to be safe. We can't risk loss of vision in order to save vision. We've already talked about that. It should be long-lasting ideally, and it should, from their perspective, have minimal impact on lifestyle. So are there surgeries available that fit this? We've already talked about the fact that trabeculectomy and tubes don't fit this because they're not safe enough to offer to patients who are just bothered by the lifestyle issues of their disease. ALT and SLT aren't going to meet this because for the vast majority of patients, they're not going to bring the pressure down enough. Well, it turns out that there is a category of surgery that meets this ideal, and that's the non-penetrating glaucoma surgeries. The problem is, even though a recent study showed that phaco-canaloplasty maintained pressure reductions of 30% on average for up to 7 years, phaco-canaloplasty or viscocanaloplasty never took off in the US. And the reason for that was that viscocanaloplasty was not equivalent to trabeculectomy, is technically challenging, and the real killer, no CPT code, no reimbursement, not going to be done. So could canaloplasty change that? Well, I think that it could. We've already seen that it's a surgical treatment. We've already had mentioned the safety profile of it. Okay, here's the safety summary compared to trabeculectomy. We don't have a comparative study, as mentioned already, but we can compare to a survey of trabeculectomy, and pretty much what you see is what's already been mentioned by Dr. Morgan. Is it long-lasting? Well, we know that phaco-viscocanalostomy, which doesn't work as well as phaco-canaloplasty, can last for at least 7 years, and we've already seen the 3-year results that were discussed by Dr. Morgan. What about minimal impact on lifestyle? Well, what is the impact on lifestyle with drops? It's because the ocular surface is worse, it's because it's expensive, and with bleb-related surgery, it's because of the bleb. The bleb worsens ocular surface disease, gives the patient a lifelong risk of blebitis, limits their ability to be active and, as Dr. Sensky mentioned, travel to exotic places or perform water sports or wear soft contact lenses. Well, with canaloplasty, because it's a bleb-free procedure, you do not have these negative impacts on lifestyle. So is it as effective as trabeculectomy? Okay. Well, there's a study that's been submitted to the journal Ophthalmology, performed by Dr. Ike Ahmed and others. It was presented at ASCRS 2 years ago. Comparison head-to-head, trab with mitomycin C to canaloplasty. The IOP result at 1 year, statistically insignificant. They were equivalent. Medication use at 1 year, same, statistically insignificant difference. But getting back to the lifestyle issue, what about vision? The visual recovery was faster in the canaloplasty group, and the best corrected visual acuity was better in the canaloplasty group. So I believe that canaloplasty is as effective as trabeculectomy, and I think we're going to see more data supporting that. But it is a technically challenging surgery, and I'm not going to breeze over that. But it's not more technically challenging than the things that you're already doing, such as phaco-emulsification. Okay? In fact, I think we're going to find that the fellows and the residents find canaloplasty a whole lot easier to take to than they do phaco-emulsification. And finally, it is now reimbursed. Dr. Morgan mentioned early on when he was doing this in 2009, reimbursement was an issue. Well, now Medicare covers it, and most PPOs cover it. There's a couple that are always problematic, that are still problematic with this, but that's getting better with time. So in summary, I think canaloplasty has the potential to be the ideal surgery, not only from the doctor's perspective in terms of reaching the intended goal of lower IOP and protecting that optic nerve, as well as being a surgery that's less likely to give you all of those ugly issues that you saw earlier. But it also is something that is going to meet the ever-increasing demands and requirements of our glaucoma patients. Thank you.